This is an ESBL producing Proteus mirabilis phenotype, and a carbapenem is the treatment of choice for serious infection, with piperacillin, tazobactam, and cefamycins, cefoxitin, as reasonable carbapenem-sparing options for urinary source disease. The report shows resistance across all tested penicillins, oxyaminocephalosporins, ceftriaxone, cefuroxime, cefepime, and functionally ceftazidime, and aztreonam, with retained susceptibility to cefoxitin, piperacillin, tazobactam, ertapenem, and meropenem, the classic signature of an extended-spectrum beta-lactamase, ESBL, most often a CTXM variant in P. mirabilis. Simultaneous resistance to fluoroquinolones, all three aminoglycosides, and TMP-SMX confirms a multi-drug-resistant isolate, which narrows the oral and adjunctive options considerably. Phenotype interpretation. The resistance pattern is ESBL, not AMPC. ESBLs hydrolyze oxyaminocephalosporins and aztreonam, but not cefamycins. The retained cefoxitin susceptibility argues against a plasmid-mediated AMP-C, which would render cefoxitin resistant, and the retained susceptibility to beta-lactamase inhibitor combinations, piperacillin, tazobactam, further supports ESBL over AMPC. Note that ceftazidime tests as a low MIC, 4, yet is reported resistant. This reflects the post-2010 CLSI cephalosporin breakpoints, under which many CTXM-type ESBL-P mirabilis remain susceptible to ceftazidime/cefepime/aztreonam in vitro despite ESBL production. These agents should not be trusted clinically, regardless of the automated MIC. Ertapenem susceptible and meropenem susceptible confirm there is no carbapenemase. Ertapenem can be hydrolyzed by some ESBLs, so confirming its low MIC, less than or equal to 0.5 here, is reassuring, and meropenem remains a fallback for any ertapenem-resistant, meropenem-susceptible strain. Intrinsic resistances of Proteus must be remembered when improvising. P. mirabilis is intrinsically resistant to tetracyclines/tigecycline, nitrofurantoin, and the polymyxins, colistin. So these common MDR rescue agents are not options here and should never be reported or used for this organism. The treatment debate. Carbapenem as definitive therapy, preferred for serious/non-urinary infection. For ESBL infections outside the urinary tract, particularly bacteremia, carbapenems are the drugs of choice, supported by the Marino trial's mortality signal favoring meropenem over piperacillin, tazobactam for ceftriaxone-resistant Enterobacterales bloodstream infection, though a reanalysis using reference susceptibility methods attenuated the statistical difference. Older observational data, specifically in ESBL P. mirabilis bacteremia, showed poor response to beta-lactam/beta-lactamase inhibitor therapy compared with carbapenems, adding caution for invasive disease. Ertapenem is convenient for outpatient/step-down use, but should be avoided in critically ill or hypoalbuminemic patients where meropenem or imipenem is preferred. Piperacillin tazobactam as a carbapenem-sparing option, best supported for UTI. For urinary source infection, piperacillin tazobactam is a reasonable alternative when the isolate is susceptible. It is here, MIC less than or equal to 8. A propensity match study of ESBL pyelonephritis, which included P. mirabilis, found no difference in clinical resolution or 30-day mortality versus carbapenems, with numerically less emergence of carbapenem-resistant organisms, and a systematic review found piperacillin tazobactam non-inferior for ESBL UTIs, suggesting a dose-optimized regimen, for example, approximately 13.5 grams per day by extended infusion. The IDSA guidance, however, recommends against piperacillin tazobactam and cefepime for ESBL-complicated UTI, favoring carbapenems, so this remains genuinely contested and should be weighted toward carbapenems for anything beyond a straightforward, source-controlled UTI in a stable patient. Cefoxitin, cefamycin. In vitro susceptibility is genuine. ESBLs do not hydrolyze cefamycins, and cefoxitin can be considered for urinary source ESBL infection, but clinical evidence is limited and porin loss-mediated resistance can emerge on therapy, so it is a secondary option rather than a first choice. Non-beta-lactam and oral options are largely foreclosed. Fluoroquinolones and TMP-SMX, the usual oral step-down agents for Enterobacterales, are resistant here, as are all aminoglycosides. Nitrofurantoin is intrinsically inactive against Proteus. Among newer/emerging oral agents, pivmecillinam, FDA approved for uncomplicated UTI, with labeled P. mirabilis activity, and the oral carbapenems tebipenem/sulopenem are potential future options for uncomplicated urinary disease, though susceptibility must be confirmed and data specific to this resistance profile are limited. Suggested approach for this isolate. Identify the infection site and severity. This is the dominant driver. Bacteremia, pneumonia, or any critically ill patient leads to carbapenem, meropenem/imipenem, ertapenem only if not critically ill/hypoalbuminemic. Urinary source. Hemodynamically stable, source-controlled leads to dose-optimized piperacillin tazobactam, extended infusion, is a defensible carbapenem-sparing choice, recognizing the IDSA preference for carbapenems. Ertapenem is an easy outpatient alternative. Confirm carbapenem susceptibility before relying on ertapenem, and reserve meropenem for any ertapenem non-susceptible strain. Avoid the Proteus intrinsic resistance traps. Do not use nitrofurantoin, tetracyclines, tigecycline, or colistin. Step down to an oral agent is constrained by resistance to fluoroquinolones and TMP-SMX. If a prolonged oral course is needed, pivmecillinam, uncomplicated UTI, or an oral carbapenem where available may be considered, pending confirmed susceptibility. The overall picture is a textbook MDR ESBL mirabilis, where a carbapenem anchors therapy for serious infection, and piperacillin tazobactam is a viable carbapenem-sparing option for urinary disease, with the added caution that Proteus intrinsic resistances eliminate several agents typically held in reserve for MDR organisms.